it's a huge pleasure to receive you here in this session. So as I told you before, we are from IDOR, the biggest net of hospitals in the Latin America. And here in this group, there are nephrologists from all over the Brazil, almost all over the Brazil, from Rio, São Paulo, Salvador, Belo Horizonte, and other states. And Annette is professor in nephrology at Linköping University and Karolinska Institute, the chair of the area of immunonephrology working group. And it's almost 10 p.m. It's almost 10 p.m. in Sweden. So once more, thank you very much to you to be here with us. And please feel completely free to give your talk. And it's a pleasure.
Thank you, Bruno. So I'm happy to be able to give this talk, and I'm really happy about the modern times when we don't have to travel, we can meet online. It's nice to meet. We had the ERA conference in Paris, and we actually met there, a lot of people, which was extremely nice, but it's good that we can do meet online as well. So today I want to talk about COVID-19, which has been something that has had a huge impact on the entire world for the third year, and especially in nephrology. What I would like to discuss is then, does COVID-19 or SARS-CoV-2 vaccine induce kidney disease? And this is more or less a talk I gave at ERA in May, and I have added some new data. So anyway, we all experienced the beginning of the COVID-19 at initially it was thought to be pneumonia and fever. Should somebody mute themselves? Okay, thank you. But it turned out fairly quickly that we all realized that COVID-19 is a multi-organ disease. And when patients could also have renal manifestations with acute kidney injury, proteinuria and hematuria, in addition to all sorts of other organ manifestations. And then within 6 months or something, there was this new syndrome that was described, which was this post-acute COVID syndrome, which is a new disease entity. So the reasons that were hypothesized at the beginning why COVID-19 could affect kidneys was in acute kidney injury, that there were a number of pathological processes taking place. For instance, fluid balance disturbances leading to pre-renal AKI, and then a complex process driven by virus-mediated injury and also toxic tubular damage. And we saw patients with cytokine release syndrome and rhabdomyolysis, and then also angiotensin II pathway activation, inflammation of the vessels, thrombotic events, interventional coagulation, and also organ crosstalk, and also a lot of drug nephrotoxicity, which is quite common in AKI and ICU situation. And people noticed that proteinuria was quite prevalent and of various degrees. And early on, lots of patients that were admitted with COVID-19 to hospitals manifested with AKI. And here it's a study from the US, almost 10,000 patients during the first COVID wave. And it was shown that patients who didn't have any AKI had an incidence rate of death of 10.8, whereas patients with AKI really did make things worse with a rate of death of 31.1. And if patients needed kidney replacement therapy, the incidence rate of death was almost 40, which was a very high risk. And patients with AKI kidney replacement therapy that survived when they were discharged, around 1/3 of the patients were dialysis dependent. And this was described in the early phase already. And one of the factors that seemed to predict dialysis dependency at discharge was a pre-existing CKD, and that was an independent risk factor. We have also looked at, we studied this in Stockholm, looking at acute kidney injury and mortality risk in older adults with COVID-19, because this was really a big killer among the older patients. And we could show here that almost 2,000 hospitalized geriatric patients during the first wave. There were 360 with COVID-19, slightly more women than men, because there were more older women, of course. And if patients had AKI and COVID-19, the odds ratio to die was 80, compared with COVID-19 without AKI and AKI without COVID-19. So this was really a very high risk with this combination of mortality. So what does this mean for the long term? If you survive, does this have any consequences? And the first study came out from China, from Wuhan, patients who had they had followed 6 months after being discharged from hospital, and there were this number of symptoms after 6 months after acute infection. They were fatigued and muscle weakness and all sorts of things that are correlated with the long COVID symptoms. But looking, and also pulmonary symptoms, but looking at the renal aspects of almost 1,400 patients with available eGFR history, 35% had decreased eGFR follow-up. And in this Chinese cohort, there were actually much fewer patients, with acute kidney injury, only 6% during inpatient treatment. And this has been a lot of discussion, why is this? And my sister, who is an infectious disease specialist and is studying long COVID, she says that in China, they admitted everybody to hospital. So whereas in Sweden, a lot of people were not admitted to hospital, and there might be a different mix of patients. But of the 1,000 patients who didn't have AKI and had normal eGFR in the acute phase, the follow-up in 822 patients after 6 months, around 13% had decreased eGFR after 6 months. And then you wonder what happened. I mean, it didn't have acute kidney injury, but why did they have decreased eGFR? So we have looked a little bit at this also. This is just a poster we presented at the ERA. We looked at 29 CKD COVID-19 infected patients with AKI that required mechanical ventilation and kidney replacement therapy at the ICU. And we had a very high mortality, 52% died, 14 survived, and we collected and published the data from the survivors. And these were mostly male and had a fairly high BMI for being in Sweden. And the dialysis was weaned in all these patients with a range of 1 to 40 days. The median stay in ICU was 41 days, and they lost a lot of weight, which we saw in many patients. And we estimated eGFR with the CKD epicreatinine and cystatin C. And we had a population-based health control group for comparison. So looking at the body weight here, you see that they lost a lot of weight, the creatinine increased, and the dialysis was started. And we looked at what happened with these patients. So everybody was very happy that creatinine improved. But when we compared to cystatin C, none of these patients really recovered fully their kidney function, and they were perhaps 1 or 2 were above 60, but they all had normal kidney function to start with. So something happens here. And these are hospitalized, very sick patients. So the biggest study looking at what happens beyond acute illness and what happens to kidney function over extended time. This is the US veteran study from Alali and co-authors, looking at 1.7 million US veterans, and of those 90,000 had COVID and survived for 30 days. And as shown everywhere else, is risk of AKI is higher, and end-stage kidney disease is also higher. But the main message here is compared to non-infected controls, 30-day COVID survivors exhibited excess eGFR decline of 3.26, 5.20, and 7.69. And these are non-hospitalized patients, hospitalized patients, and ICU patients. So there is a process with the kidney function that is induced by this COVID infection. And it's interesting that it's also measurable in patients who were never hospitalized. There is no data on proteinuria in this study. And we have to remember that the US veterans are mostly older males and mainly white. But the authors point out that post-acute COVID-19 care should involve attention to kidney disease. And this is also a German study looking at 443 individuals after COVID infection, followed in median for 9.6 months. And most of those were not hospitalized. And they could see that the number of organ systems were affected with the respiratory system, cardiac system, and signs of deep vein thrombosis that they had gone through, and also lower glomerular filtration rate. Looking here, not the same range as these older US veterans, but still a significant effect. And they therefore recommend systematic organ screening 6 to 9 months after mild to moderate SARS-CoV-2 infection. So what do we know about the kidney as a target organ? Early on, there was data from Wuhan, postmortem data that from 23 out of 85 patients with who had 23 patients who had AKI, and they showed that there was evidence of binding of SARS-CoV-2 virus to ACE2 receptors on tubular cells and podocytes. And there was also some immunohistochemistry study looking at the complement depositions in tubular cells. And other studies have found SARS-CoV-2 virus in urine, and that's been associated with albuminuria and reduced GFR. And here is a German study looking at the sort of more mechanistic approaches. How does this work? And they first started out with COVID-19 patient that presented with increased tubular interstitial kidney fibrosis compared to controls. And these were from autopsy data. And then they built a model with the SARS-CoV-2 virus infecting kidney organoids. And they could see that this was driving fibrosis through different mechanisms and entering the cells through ACE2 and priming by another receptor. And this increased expression of collagen and upregulation of pro-inflammatory and pro-fibrotic pathways. So their conclusion was that SARS-CoV-2 infection stimulates this pro-fibrotic signaling in human kidney organoids. And in their model, they could also inhibit this process by a protease blocker, which would reduce this process. So perhaps this is what induces this process, and there's some pro-fibrotic mechanism that is starting, and And we don't know if it stops by itself or it continues. And that is why it's really important to follow patients, to know if there's something you can do to use some kidney protective drugs and things like that. So this is a field that is very interesting, and the follow-up story of this will be very important. So recommendations for follow-up after AKI at the moment is looking at kidney function labs for patients who've had COVID-19, looking at hematuria and proteinuria. And we don't completely know yet if SARS-CoV-2 induces kidney disease, not only damage of this profibrotic process. It's important to follow blood pressure and consider long-term kidney protection in patients who do seem to have problems with their kidneys after SARS-CoV-2 infection. So this question, if it does induce or trigger inflammatory kidney disease, that's kind of tricky questions, because we have all seen cases and we have diagnosed COVID-19 and vasculitis at the same time, other types of glomerulonephritis, post-COVID, IgA nephropathy, but we also have seen cases and relapses after vaccines, and I will discuss that now. And what we do know is that there is, and it was fairly early on published about this COVID-19 associated collapsing glomerulopathy. And it seems as the virus in itself seems to have a toxic viral inflammatory cytokine effect on podocytes in combination with APOL1 mutation. And we will have this collapsing glomerulopathy. And this is very similar to what we have seen in HIV, this HIV-associated nephropathy. Other glomerulonephritis that have been reported, and early on there were a number of papers about anti-GBM disease. And there was a discussion whether there were clusterings of this anti-GBM disease, and that the trigger would be the COVID infection. But since anti-GBM disease is so rare, so even if the incidence would rise from 1 to 2 million, to 1 to 2 per million, that would not be a very big effect. It's interesting maybe from a mechanistic point of view. But there are cases that have been reported, new glomonephritis, but it may be a coincidence and not really a causing effect. We don't really know that for sure. So this is a case. This is a 51-year-old man who has hypothyroidism treated with levothyroxine, but otherwise healthy. And in the middle of April 2021, he had new symptoms with fever, cough, and dyspnea, and he took a COVID test that was negative, but his daughter that he was living with had a COVID PCR positive test. He was afebrile after 3 days, but still had these pulmonary symptoms, and then started coughing blood and came to the ER mid-May. And at that time, he had a creatinine of 300 micromoles per liter, and also hematuria and proteinuria. His CRP was elevated, his hemoglobin was low, he had an increased D-dimer, and the chest CT showed bilateral granular opacities, but also alveolar hemorrhage. And he had a COVID PCR test that was positive at this time. So that was kind of difficult because this could all be COVID, but it didn't explain everything. And he needed a lot of oxygen, but wasn't sick enough to be admitted to the ICU. So more tests were done. So he turned out to be MPO-ANCA positive, anti-GBM negative. And at this time, they also measured the virus in the serum, and it was positive. And there was a new chest CT with mediastinal lymph nodes that was more atypical for COVID-19 pneumonia, perhaps more indicative of vasculitis. He had swollen, painful legs, and ultrasound showed thrombosis in both his legs. So I'll skip this. So we had to treat what we thought was the main problem, but also combining for COVID. So he was given methylprednisolone, low molecular heparin, and we thought that he needed immunosuppression for his obvious ANCA-associated vasculitis, but we didn't choose to use rituximab because we had studied this and read that it could be bad for COVID-19 and also for the vaccine effect. And he also had a spiking fever and given antibiotics. We studied plasma exchange and gave him cyclophosphamide. And then he improved, oxygen was discontinued, CRP and creatinine improved. And then he was switched to this glucocorticoid oral and cyclophosphamide schedule. And we never switched him to rituximab. And he was discharged after 4 weeks and added apixaban. And now he is followed at a different hospital. But this was mainly the vasculitis, but perhaps triggered by the COVID-19 or a coincidence, we don't know. So here is a registry that we participated in of COVID-19 infection patients with glomonephritis, looking at what happened to them. And there were 125 patients with glomerular disease, and controls were patients without glomerular disease. And here, looking at the patients, what happened to them after adjustment for pre-COVID EGFR and other confounders, we didn't really see a difference in mortality and AKI between glomerulonephritis patients and controls. But the pre-COVID EGFR was the main predictor of AKI, which is very similar to the US studies looking at AKI. And patients with glomerulonephritis developed AKI, who developed AKI were less likely to recover to the pre-COVID EGFR. But associated with lower post-COVID-19 was a shorter duration of glomerulonephritis diagnosis if they had higher proteinuria already before COVID and a diagnosis of SGS, minimal change disease. But this study didn't really show that glomerular disease patients had a high risk of severe outcome unless they had a reduced EGFR, more proteinuria prior to COVID-19. Looking at ANCA-associated vasculitis, there are a number of studies from the UK looking at vasculitis patients, and they could show that glucocorticoid use or presentation and comorbid respiratory disease were associated with severe outcomes in COVID-19. And other studies have shown that rituximab increases the risk of severe COVID-19 in vasculitis patients. And we have looked at this in a cohort of 310 patients here in Stockholm and Uppsala. And we had 29 patients who were diagnosed with COVID-19, of those 9 severe, and we had 4 deaths. And significant risk factors for severe COVID-19 were impaired kidney function prior to the infection, more intense immunosuppressive therapy, and then a trend for age. Maintenance therapy with rituximab was not associated with severe COVID-19, and that has not been shown before. So the last part of my talk is about vaccines and glomerulonephritis, and we have had this fantastic development of vaccines, and which has been very helpful, but questions have been raised about if they can induce glomerulonephritis or not. So I have another case. This is a 50-year-old woman, and she was diagnosed with minimal change disease in 2007. And she had a relapsing, quite complicated disease. Eventually, I treated her with rituximab in 2008 and 2011. And since then, she has been doing really well. Once she had traces of albuminuria in 2013, with a spontaneous remission and normal kidney function. And she hasn't been on any immunosuppression for 10 years. So in August 2021, she has a first dose of mRNA vaccine. 3 weeks later, she calls us and says that she's a bit swollen. Her plasma albumin is 30, and she has a urine albumin creatinine ratio of almost 100 milligram per millimole. And then we say, well, we'll check you in a couple of weeks. And then she had a spontaneous remission, so that was fine. Then she had vaccine dose number 2 in January. 2 weeks later, she again has lower plasma albumin and an increase in the urine albumin creatinine ratio. So this time she didn't have a spontaneous remission. I started her on prednisolone to see if this would be easy to treat, but 6 weeks later she still had the same level of plasma albumin, even though albuminuria was a bit lower. So we decided to give her 500 milligrams of rituximab, and she was given the vaccine, third vaccine prior to this. And after that, she has been in remission. So it was pretty easy to treat her. In this case, it was quite obvious that the vaccine somehow triggered, and this has been described in many case reports by now. So this is a study from the US looking at a series of 29 cases of patients who received mRNA vaccines, and 2 of them also adenoviral vaccines, and 28 de novo glomonephritis, and 1 actually transplant patients. And here they could show that these patients did a low number of patients actually can have a flare of their glomonephritis. But looking at the biopsy diagnosis in general, looking at comparing previous years, and this has been looked at different studies, it doesn't seem that there's a big trend for new diseases, biopsy-wise, but this vaccine association seems to be happening, even though it's not very common. And this is also a study from France looking at nephrotic syndrome patients and relapses, and number of shots for relapse. So 18 patients relapsed after 1 vaccine, 7 after 2, and 2 after 3. And they treated them with steroids and other immunosuppressive drugs, and almost all of them went into remission. So it seems fairly easy to treat. But this is a low number of patients. We need to be aware that in rare cases, this may trigger relapse. That is easy to control, but there's no real strong contraindication against vaccines, even in those cases. You can manage this. It's more important for them to be vaccinated than not. So the link between vaccine and is it common or not? So this is a 100 study, a paper that was published in February of this year. One of all these patients, in August, this is a year ago, 1.8 billion people who were fully vaccinated, and only 295 cases have been reported to the WHVG base. And this highlights the safety of the vaccines. So the vaccine and the COVID-19, there may be some shared pathophysiological links or some antigen cross-reactivity with the spike protein. There might be genetics that contribute, or actually unmasking of underlying disease, that the patient already had the disease, but the vaccine made it more obvious. And then thinking about how the dosing may affect it. The Pfizer vaccine is 30 micrograms, whereas the Moderna vaccine is 3 times as much. So maybe the Moderna vaccine will induce this more because it's a dose response thing. But in general, the vaccine is very safe. If you would have a flare or something similar, you can treat this fairly easily. So to conclude, SARS-CoV-2 infection and paths to kidney injury. So COVID-19 is a multi-organ disease that can also affect the kidneys, mostly seen as AKI, frequently with concurrent albuminuria and hematuria. And this also increases mortality in COVID-19 infection. But with the better treatments, like dexamethasone for severely ill patients, the incidence of AKI is actually reduced, and perhaps the newer mutations may not have the same effect on the kidneys. We'll have to wait and see. But I think we all can agree that follow-up of patients is important, especially if they did have AKI. And SARS-CoV-2 virus may trigger immune-mediated kidney disease as well as relapses and AKI in patients with glomonephritis. ANCA-associated vasculitis patients seem to be more at risk of severe outcome. But the GFR is a very strong predictor for poor outcome, which has been shown, of course, in several studies that the kidney patients are a risk population. But we think in ANCA-associated vasculitis that patients who have active disease and immunosuppression are also a higher risk. SARS-CoV-2 vaccine can trigger disease relapses and unmask underlying disease, but these are rare and fairly benign and easy to treat. And as I said, vaccines are more important to promote in at-risk populations. So for the long term, there are things to be considered. Post-acute COVID syndrome is a new disease entity, and I think that the kidney function decline is obviously one of the manifestations. 12-month follow-up studies have shown that kidney function may be affected long-term. The mechanism behind this is not clear, but there may be an element of profibrotic mechanism that is triggered. So post-acute COVID-19 care should involve attention to kidney function. And we all know, of course, as the kidney doctors, that it's important to have to save the kidney function, not because of this increasing risk of cardiovascular complications and mortality when the GFR is reduced. So if we have a number of new patients that we haven't thought about that are at risk for losing their kidney function or having a reduced kidney function, then we'll have a new high-risk cardiovascular population that we hadn't considered before. So this is really important for us to consider. So of course we promote vaccines, and what we still see quite a lot of breakthrough infections, and this is also from the people behind this veteran study looking at long COVID after breakthrough SARS-CoV-2 infection. And it seems as though you get more kidney problems. You can get more kidney problems with more infections. That seems that there could be an additive effect of several infections, and this has to be followed. And it seems to be a difference between patients who have a good immune system versus a immunocompromised immune system. The risk is higher in immunocompromised patients, and that would be the transplant patients, patients on dialysis. They may not lose their more kidney function on dialysis, but they may have other cardiovascular complications and other organ damage that we need to consider. So this is an important story to follow. So this is, I think I started talking about COVID-19 in April of 2020, and I have the same last slide for all these talks, because this is, I feel that we don't know everything, but we have to manage it what we have, but do the best you can until you know better, and when you know better, do better. I think that's a good quote to end this talk with. So thank you for the attention, and if you have any questions, you're welcome.
Thank you very much, Annette. Please, guys, feel free to ask questions to Annette.
Can I make a comment?
Sure.
Yes. Hi. Thank you
How is
so much
baby? It's
for
okay, Camilo?
Well, she's
babies.
okay. She will never stop. She will never stop crying anyway.
Yeah,
So
yeah.
we'll have to get used to it. You know, she's
Yeah.
only 6 months old, so
Yeah.
she's trying to communicate. Actually, she's
Yeah.
saying hi.
She wants to say
So-
something. Yeah.
She's saying hi right now.
Yeah.
I can't show you. She's like about to eat. So anyway, thank you for this lecture. It's interesting how when COVID started, we were all in the dark. We didn't know anything. And now as the data comes by, it seems that the most important message is still the one that you gave, like no matter what happens, it's important to be vaccinated, and whatever comes with the kidney function, we'll deal with it. And it's the same, and it's even more important amongst kidney transplant patients, as we see that the immunity that they get after vaccination, it goes up and down. So they need like 4 and 5 doses so far. So I think no matter what can happen to the kidney disease, it's important that the patients get the message that they have to keep in touch with the nephrologist, that their kidney function has to be monitored, and they have to be vaccinated. So I think even though 2 years have passed by, we still get that same message. So it seems like we're going the right direction. Thank you so much.
Thank you. Can I ask you something about what is the situation in Brazil when it comes to drugs and, like antibodies for immune suppressed patients? Do you have access to it, or what do you do?
Well, I work in a single center with transplantation so far, and still we tried to do, in the beginning, we tried to do the IVIG for the patients, expecting that their response would be better at the beginning. But we noticed of course, it was a small cohort, and we had to get like the perfect timing of the symptoms, like from 3 to 5 days, and it was not always accurate. But we didn't see much of a difference. So actually that experience we're making, that study, we ended it in the beginning because we didn't see difference. But in the beginning of the COVID, we had a lethality of 30% amongst the kidney transplant patients. And it got lower as it goes. Now it's about 10%. So it's still a lot, but it's much better. And we attribute that to the vaccination, of course. And when they have severe cases, we reduce I have dogs as well, so you might listen to them. So the immunosuppression, we would take out the third drug initially, or all the immunosuppression, keeping only the prednisolone as the cases were more severe or not. But that's the experience I have so far. Maybe Bruno can tell us more about it.
Yeah. So I don't know, what we do is we reduce immunosuppression a little bit in transplant patients, but then we treat them with remdesivir. If we're early enough, we can give them this Evusheld, which is AstraZeneca's, but we don't have many doses, 2 antibodies. And then we have now Paxlovid, which you can't use in the transplant patient because of the interactions, but in other immunosuppressed patients. So we have some drug, but I think we started using corticosteroids quite early when this recovery study from the UK was published. And that seems, their data also shows that it's less AKI if you use that pretty early in hospitalized patients who need oxygen. So there's a lot of valuable information from some very good studies that have not been too complicated. So but what I've read lately, that there may be some with the new mutations, is that there is more resistant to some of the treatments. So there will still be new drugs developing and new strategies. I'm a vasculitis doctor, and our problem is that we have given so much rituximab to our patients that they don't have any response to the vaccine at all, which is a big problem. So we will live with this for many years, at least in nephrology, I think. It would be important for us to defend our patients and look for their best interest.
Nice. Please, guys, more questions.
Hi. Thanks for Dornet for the presentation. It's a good thing to talk now because we saw a lot of COVID, acute kidney disease COVID, and I think we all continue see the patients in post-COVID in the late when they survive. But do you think there's a place for the new medications like dapagliflozin, cenerenone, on the future of this patient, like this fibrotic disease, long COVID? Do you think there is a place for this new therapies?
I think you have to consider it. I mean, if we're going to use these drugs for as kidney protective drugs, and you have a patient who has kidney damage, irrespective of what it is, it could be diabetes or COVID, or actually, as a matter of fact, these patients have high risk of diabetes, cardiovascular disease, and all this. I think that would be a good idea to consider it. If they have less than 16 GFR and they have proteinuria, and you see that the kidney function is deteriorating, I think that would be I mean, that irrespective what the mechanism is, that's what you probably is one of the things you can do today with these patients. But it would be interesting to study it, of course.
Okay.
But I think that we will use it.
Yeah. Yeah, agree.
Mm.
So since Sabrina stole my question,
Okay.
I'm going to ask another thing. Do you have any perspective about the kids? Because here in Brazil, we start to do the vaccines on kids, like 3-year-olds, 4-year-olds, and do you have something to talk about that?
Yeah. So it seems that the children have a good response to the vaccine. Actually, the children can also get long COVID. I don't know if it has been studied, you know, the kidney function has been studied, but apparently they seem to have a protective effect from the vaccines. The younger children have less side effects, but they also get lower doses. Whereas there's like a small group of patients adolescents that would have high risk of myocarditis, but it seems to be transient. It's much worse to get any kind of heart symptoms from COVID infection in itself. So I think it will be interesting to see. Actually, in Sweden, we don't vaccinate the kids under 12, which is it's like a political thing, I would say, rather than a scientific thing. But from the countries that have vaccinated children, I think they have fairly good results. So and they have adapted the dose to be much lower. But the kids obviously will get infected, and they will infect other. And now it's so infectious with this Omicron variant. So, I mean, in the schools and everything, that I think it's a good idea to vaccinate children. But you have to follow them, of course.
So, any more questions?
All right.
Okay, Annette, so
Yes.
It's almost 11 p.m.
Yeah, I know. I have to
here,
go
so-
back to my research application.
Well, thank you.
It's okay. It's okay.
Okay, thank you very much for
Yeah.
your talk, and
Yeah.
please, you have the open space here to talk whenever you want. And thank you very
Okay.
much for your
Okay.
presence today. Okay.
Yeah. Okay. Thank you for the attention and the
Okay.
invitation. Bye
Bye
bye.
bye.